Hello, this is Ryan Hakimi, and today I'm going to be speaking on billing and coding in the Neuro ICU. I'm a neurointensivist in Greenville, South Carolina at the University of South Carolina. I don't have any disclosures. Our objectives for today's talk are to describe critical care billing by providers. We will list buzzwords and phrases to avoid in critical care documentation. We will describe the importance of documentation for risk adjustment, and we'll define what is an HCC. To begin with, the definition of critical care is an important place to start. So the patient must be critically ill, so illness or injury at the time of presentation, which impairs one or more vital organ systems such that there is a high probability of imminent or life-threatening deterioration in the patient's condition. The provider must treat critical illness using high complexity decision-making to assess, manipulate, and support vital systems to treat single or multiple vital organ system failure and or prevent further life-threatening deterioration of the patient's condition. The care requires the personal attention of the provider, and the care must be provided at the bedside or on the floor or units where the patient is housed. The care must be medically necessary. Treatment or management of the patient's imminent deterioration is required. So from a practical standpoint, what does this all mean? In essence, if you as a provider were not standing at the bedside manipulating medications, treatments, therapies, or interpreting complex data and diagnostics, there would be risk of organ damage or death. So that is how I think about it every time I decide whether this patient warrants critical care. I think if I were not there doing the multitude of things that I'm currently doing, would there be risk of organ damage or death? And if the answer to that is yes, that meets the test for critical care. If the answer to that is no, or if it's a gray area, then that does not meet the criteria. Critical care billing is physician billing. It applies to advanced practice providers, but most of us have a physician rounding in our neuro ICUs. It's billing on the work done by the physician only. So do not acknowledge the APP's note. The physician's note may be in a separate or the same document as the APP or resident. However, if it's at the top of your documentation, we use Epic at our system, we simply do not acknowledge the presence of the APP or residence note below us, because with APPs, split shared is not allowed. Split shared means when you're combining the efforts of both the advanced practice provider and the physician to come to a composite amount of work to determine how to bill. However, on non-ICU patients such as evaluation and management, E&M patients, or floor patients, split shared is allowed. And in essence, in those cases, you're taking credit for the work done by the APP and the work done by yourself and billing a composite amount of either time or effort. So it is very important to remember split shared is not allowed for critical care billing. Critical care time must be documented in the note as an exact number. Billing will be based on the scale below. You cannot document 30 to 74 minutes of critical care time. You have to write a specific number. In addition, it's important to be aware that each increment of critical care after 74 minutes is taken into account by groups of 30 minutes. Therefore, if a patient already has a 99291 billing by physician number 1 during a given calendar day, critical care provided by physician number 2 of the same specialty and in the same group will be billed as a 99292 if the total exceeds 74 minutes, and it will be billed in increments of 30 minutes. For example, for 75 to 104 minutes of total time between physician 1 and physician 2, physician number 2 would bill 99292 for 1 unit. This also brings about importance in noting that physician number 1, the so-called daytime physician, will often have to have their documentation done prior to their colleague taking over. in order for their colleague to know how to appropriately bill the patient. So what counts as critical care time? It's the time spent at the bedside, examining the patient, the time spent in the unit, reviewing the patient's history, images, medications, labs, etc. Time spent obtaining the history from the family in person, not on the phone, if the patient is unable to provide it. So therefore, if an extensive amount of time was put into obtaining the history from the family on a face-to-face encounter, it would be important for you to document why you were not able to get the information directly from the patient, such as the patient is intubated and sedated. Time spent documenting if it's done on the unit where the care was provided. For example, not at home later that evening. This also impresses upon physicians to document on the same date of service. Many people accumulate a backlog of charts and then go document in their off-service weeks. That really limits the ability to bill critical care, because the time that you spend at home on the following week or following evening or whatever is not time spent in the hospital, in the unit, and therefore the amount of time put into that voluminous, beautiful document that you have put together is not counted. Time discussing the plan of care or subsequent medical decision making. Example, discussing the possibility of intubation, PEG tube placement, comfort care, not updating the family. Update will be discussed later as one of our buzzwords to avoid. What does not count as critical care time? Time associated with a procedure. Example, sedating the patient for intubation is bundled into the procedure's CPT code. The time spent caring for a patient in the ICU who no longer meets the definition of critical care, such as when there are no floor beds available. Any time that involves speaking on the telephone with family or other providers. It must be face-to-face, or now, as of earlier this week, approved by CMS via telemedicine encounter. However, this is so new that none of us have figured out how we're going to create separate telemedicine encounters to be able to capture the billing of those family discussions that are occurring remotely, and at the same time continue with critical care billing within a different encounter for which you are caring for the patient. Time spent updating the family on a patient's condition without discussing goals of care, treatment options, etc., does not count. Critical care billing does not have to be provided in the ICU. For example, the patient admitted to the floor develops respiratory distress, is NT suction, placed on BiPAP, and transferred to the ICU. If the care was provided by the provider at bedside, not just ordering the RT to do it, you can bill for that time if it meets the 30-minute minimum. So one of the things that I personally do is that I document that I personally transported the patient from the floor to the ICU because of the following things. So that time spent with the patient does count as critical care. So here's another example. A patient with a high stroke scale presents to the ED, and the provider evaluates for TPA and the possible need for intubation and pressors. So therefore, it can be done on the ED, it can be done on the floor, it can be done anywhere. It just has to meet that definition, like we said, that if you were not there to manipulate medications, treatments, therapies, and interpret diagnostics in an acute fashion, would the patient have harm? So what are some buzzwords and phrases to avoid in your documentation? Update. So you need to, where appropriate, of course, state discussed options of care, including. So one of the things that we often discuss is that I will write down that I personally discussed options of care with the patient's daughter at bedside, including maximal medical care, which would likely entail endotracheal intubation and potential need for PEG tube placement, comma, DNR status, comma, and comfort care. Another thing to avoid is saying the word stable. Often our radiology colleagues report will say stable ICH, or stable midline shift, or stable ischemic stroke. And unfortunately, that gets pulled into our documentation for which we are held responsible. So if somebody has 1 centimeter of brainstem compression, just because it is unchanged from one CAT scan to the next does not mean that the patient does not need critical care. So try to avoid the use of the word stable and say unchanged or static. History of. So we're all taught in medical school that when we present patients, we say this is a patient with a history of blank, and so on and so forth. Instead, we need to say with, and we'll show that in a moment, and we need to list that as an active problem when appropriate. More about this later. Unable to assess. You must state the reason. Although it may be inherently obvious to us as providers that a patient that is intubated and on high-dose sedation is unable to provide a medical history, it cannot be inferred because it is not documented. Therefore, you must state unable to assess due to the patient being intubated and sedated. Now, that's the provider-based billing. What about the hospital? So the hospital billing, believe it or not, is completely different and has different objectives to draw from the documentation. So there's something called hospital risk adjustment. So every hospital tracks a risk-adjusted mortality index called RAMI, using the observed deaths, O, divided by the expected deaths, E. A RAMI greater than 1 means more patients died at your hospital under your care than expected for their given condition and comorbidities. A RAMI of less than 1 means less patients died than expected for their given condition and comorbidities. The lower the RAMI, the better. The RAMI usually accounts for about 20% of the hospital's star ratings, which is now how CMS is going to determine, in part, how to pay hospitals. In addition, patients have access to the hospital star rating, which then allows them to choose the hospital of their choice to seek medical care. So as you can see, this matters substantially from a financial standpoint for our health systems. So how is expected death determined? It's important to know that the H&P serves as the index document which defines the state of the patient upon admission, from which the illness level is determined and what conditions are present on admission. This makes the H&P the most important document for improving your hospital's RAMI. The ICD-10 diagnoses on the H&P determine the patient's level of illness at the time of hospital presentation. Learning the correct ICD-10 terminology is the best way to document the problem. This is important as those who review the documentation do not have a clinical background and are not allowed to infer anything that is not documented. So let's pause for a moment. Those who are reading your chart are abstractors, and they are not allowed to infer that the patient is ill, even though those of us that are medical providers, if we read that chart, it would be extremely obvious to us that the patient is critically ill. Here's an example. Patient with low blood pressure due to low hemoglobin requiring 45 mics of Levophed. Any of us that are medical providers, if we read that sentence, we know this patient is extremely ill and can die at any moment. To the abstractor, the diagnoses are low blood pressure and low hemoglobin, which can also be seen as outpatients. That sentence in no way, shape, or form to an abstractor conveys that this patient is critically ill. So you need to use the correct terminology. You need to document hemorrhagic shock refractory to vasopressor therapy. That is the kind of terminology that the abstractor understands and says, oh, this patient indeed is critically ill. Learning the HCCs and documenting them is quite valuable as a provider. So an HCC is what's called a hierarchical condition category. It's based on CMS's use of a risk adjustment model that calculates risk scores for aged and disabled Medicare beneficiaries. These scores represent the expected medical cost of a Medicare member in the coming year. So basically, the number of HCCs that are documented, again, appropriately, we're not suggesting that anybody documents something that is not correct, determines how ill the patient is and also determines how much the hospital gets paid. So there are currently 86 HCCs as of 2020. So here are some common neurocritical care HCCs to use in your documentation. Brain compression, not midline shift. Midline shift is not a recognized term, even though it is for physician billing, it is not a recognized term for hospital billing. Cytotoxic cerebral edema, not CT shows swelling. Acute respiratory failure with hypoxemia, not ventilator-dependent respiratory failure. Ventilator-dependent respiratory failure is a code that is used for chronic vent facilities. Intracranial hemorrhage, not head bleed. And there are other ones such as coagulation defect, not elevated INR, so on and so forth. What else can we do to help our documentation to show how ill the patient is that we're caring for? We need to eliminate this habit that we have and that we were taught in medical school and is continuing to be taught in medical school, to eliminate the term history of from the history of present illness. So here's an example. The patient is a 54-year-old male with a past medical history of hypertension, hyperlipidemia, and diabetes mellitus, who presents with an acute left MCA ischemic stroke. So the abstractor sees that sentence and says history of, and that eliminates those three diagnoses and says, oh, this person has an acute left MCA ischemic stroke. So that is the only part that will contribute to the patient's RAMI, as the other items are historical, or what's called Z codes within ICD-10. One should document the patient is a 54-year-old male with hypertension, hyperlipidemia, and diabetes mellitus who presents with an acute left MCA ischemic stroke. Then each one of these diagnoses, hypertension, hyperlipidemia, and diabetes mellitus, would serve as an assessment, and there should be an associated plan. Even if the plan is to continue the patient's home medication, it contributes to their RAMI, and the documentation determines how ill this patient is. Clearly, there's a difference between a 54-year-old who comes in with a stroke in comparison to a 54-year-old with hypertension, hyperlipidemia, and diabetes mellitus who presents with the same stroke. You should also document each individual electrolyte abnormality and state the replacement plan. This is something that we as intensivists often overlook in our documentation because to us, a potassium of 3.2 is not concerning, and it is just assumed that we will replace that low potassium. However, if we document hypokalemia will initiate replacement therapy, that adds to the illness level of the patient present on admission. By documenting every condition as an assessment and having a plan for each, our system was able to reduce the RAMI for subarachnoid hemorrhage by 400% and ICH by 120%. So you can see that the documentation on the H&P matters. Often the H&P is done hastily as we are focused on stabilizing the patient. It is important for us to understand how our documentation on the H&P can impact hospital reimbursement, expected length of stay, and whether a case will go before the hospital's mortality review committee and our own risk of litigation. It is also important that for many of us, the original H&P is often done by another service. So for example, there might be one neurology admitter or neurocritical care or neurosurgery admitter within the ICU, within the emergency department, who sees all patients who come, does their H&P, and then distributes them to the appropriate service. Unfortunately, that individual's role is not to itemize every one of these problems. And therefore, they may be focused on whether the question is to whether to give TPA or not. or to determine whether the patient's being admitted or things like that. So therefore, it is very important that neurocritical care teams document their own H&Ps, because we don't want to have to be responsible for the documentation of others. Now, this is much more challenging for institutions where neurocritical care is a consult service. And unfortunately, again, the H&P done by neurosurgery or medicine or other services like that may be lacking in this level of detail needed for the risk adjustment. I want to thank you for your attention and hope that this spurred some beneficial ideas for your health system. And I look forward to talking more on this subject in the future. Thank you.